Hey guys, so this is another lecture, a long lecture. So this is my long lecture on upper respiratory disorders. So we're going to be covering hypersensitivity disorders, allergic rhinitis, anaphylaxis, acute sinusitis, and influenza, and a bunch of meds. And so if you're looking for shorter, more simple videos, there are other videos on this channel. Go under Unit 1 and find those there. This is a long lecture for those that need to spend a little bit more time because I talk super fast or want a more detailed explanation of some things. So let's get started. So to get started, let's talk about hypersensitivity disorders. So there's a lot of disorders that are going to be covered in this unit that can be classified as hypersensitivity disorders. And you don't need to, there's like types 1 through 4. You don't need to go in depth about what all those hypersensitivity disorders are. But what you do need to know is in general, what is a hypersensitivity disorder? And so what it is it's effectively where the immune system is overreacting or over-responding to some sort of allergen that's introduced into your system. So think of it this way. It's kind of like that family member who overreacts. You say something and they're super sensitive and they just take everything very personally. This is what is happening in your body effectively. So something comes in your body and maybe it really is an allergen, it's irritating, but your body's like, oh my gosh, I have to do something right now, I've got to fix it. And so it exaggerates and does this kind of hyper response, which leads to different reactions. And these reactions can manifest as skin problems like dermatitis or hives. You can have swelling as a result of it. And then when you get to more serious, you can have like the most serious thing that can happen is anaphylaxis or your throat closing, et cetera, which we'll talk about. And then there's also things like allergic rhinitis is a more chronic upper respiratory hypersensitivity disorder we'll talk about. And we'll talk about asthma too, which is an overreaction that leads to some more serious symptoms. And the thing that can happen with this, it can happen early. Like, you know, I know my husband knows someone who he just walks into a Chick-fil-A and just by walking into the Chick-fil-A, he like starts getting an anaphylactic reaction. So, you know, sometimes it can be super early within seconds of being exposed. Or sometimes there's a delayed response. So like think delayed response would be something like poison ivy. You touch it and then sometimes you don't really see those signs show up till the next day. So here's some example. Here's some like some hives and welts that people have. Here's some angioedema where the lips and stuff like that and stuff is getting swollen as a result of exposure to an allergen. Again, your body's trying to help, but its reaction was a little too intense. Your immune system's a little too strong. So what we do to diagnose allergies or to see what people are allergic to, especially if someone's kind of showing up and they're having a lot of reactions, we want to find out, okay, what are they going to react to so we don't keep having these reactions. In order to do allergy testing, to know what people are allergic to, they have to be off medications that are going to suppress their immune response. So in other words, suppress their immune response. So in other words, if I'm trying to figure out what you're allergic to, I can't be on medications, or you can't be on medications that are going to be suppressing your allergic response. So like, for example, if I'm on antihistamines or steroids and I'm allergic to something, I may not respond in the same way I would if I was not on those medications. So I need to see just point blank, just your immune system. What are you going to do if I expose you to certain allergens? Patients shouldn't be left alone during this testing because they can, for some of them, they can have anaphylaxis. So we always want to stay in the room. They have to stay usually for a while to make sure they're not going to have a delayed reaction. And they place the allergen under the skin, usually on the back, kind of like in these pictures where they have all of the, and they have them all numbered for all the different allergens, and they kind of just show up, like they show these ones that are red are ones that the patient's reacting to. Usually they can receive results within minutes because usually most reactions are pretty quick. And then there's the patch test like this one, which is looking for delayed reactions, and that can take up to 24 to 48 hours. The great thing about allergy testing is once we find out what you're allergic to, and you can see some people can be allergic to a lot of things, then we can do what's called immunotherapy, which we're going to talk about on the next slide. So if I know what, if people find out what we're allergic to, and I always use my husband as an example because he's allergic to like all of Texas, is that, you know, what he did is he got allergy testing and they found out like the 3 or 4 big things he was allergic to. And then what they did is they pretty much made a vial of all of his allergens together. And then they made like really like small doses of it and then larger and larger doses of it. And what I did for years, I injected him with his allergens. So the point of immunotherapy is to try to expose you to these allergens to hope to decrease your response or desensitize you to what you're allergic to. So usually it's subcutaneous. It can be done sublingual. And like I did it for my husband, but if he wasn't able to do it for himself, he could go in daily and get shots at like his clinic, but it's so much easier to do it at home, etc. And he was just too much of a wiener to do it by himself. So gave him those exposure to those allergens. And like for him, it was not a guarantee, and it did not lead to any improvement, sadly for him. Still really poor allergies. It's hard in Texas. There's so many things to be allergic to, but it definitely can lead to improvement for some people. So like some people, for example, maybe they have a partner who has a cat and they really want to be able to live with their partner because they love them. So as long as they can do this, and it can help to decrease. And the point of it is that you're not just starting and saying like, here, I'm going to just lay with a cat, even though I'm definitely allergic to it. You know, you're slowly introducing that allergen more and more to decrease your body's response to it. It can take a few years to do it. And then they need to know that with each time they get like a higher dose that they have to, there's going to be a higher chance of them having a reaction. They need to know what the reactions are going to look like, and they're going to need to have an Epipen. So like with my husband, he had to carry an Epipen after anytime, like I'll give him a shot in the morning, he would have to carry his Epipen with him to work. And then anytime we went into the clinic, I had to do teaching and other stuff like that, and like went through a whole thing through insurance. And so we had to bring the Epipen in with us or they would not see us. So they have to have that on them, because even if they haven't ever had an anaphylactic reaction, we don't know what's going to take to cause it. So we definitely do not want to get to an uncomfortable place like that. So what else can make it better? So other things that can make, general hypersensitivity disorders better is knowing and avoiding triggers. So keeping a diary and kind of keeping an eye on like, okay, what are the things that are bringing up this allergy can help. Preventing reactions through medications like antihistamines, which we'll talk about on the next slide. We can treat an active reaction because at the end of the day, it would be great for hypersensitivity to just not react. So prevention is key. If I know my triggers, or if I can take medications before I'm exposed to it, that's great. But let's say I'm already exposed to it, can't do anything about it, I've already been exposed, then I can do things like steroids, which help suppress my immune system. The thing we always worry about with steroids, is that there's a concern for infection. So like steroids are great at decreasing inflammation and suppressing the immune system, but they can increase my risk for infection, and they also increase my blood glucose. So I have to be careful with patients that are diabetic. They also can take like a topical, like if it's just a hives reaction or skin reaction, it's really itching, then they can put on like things like calamine lotion. And then in an emergency, we would use things like epinephrine, which we'll talk about epinephrine too. So let's talk about antihistamines. So there's a lot of upper respiratory meds. So do your best to kind of keep up with them. Like I talk about this for all meds, is it's really key to not just don't lurk, please don't. Please don't, also don't just look at these meds and try to memorize them, but really try to see what you can do to bring it together. And the way that you can bring it together is not just putting this on a flashcard and reading it over and over and over, because you can memorize this and still not get questions running the test. You have to look at it in scenarios and situations. And so doing case studies, making sure to do practice questions that are application level, where they're actually putting you in situations, and really start thinking about, as the nurse, when I give this med, what things could come up and what am I going to do about them. So antihistamines are one of the few meds that can not only prevent attacks, they can also treat them. And so it can relieve symptoms of allergies like itching, sneezing, and runny nose, and also can prevent attacks in general. Or even if you're having like a skin reaction, it can help to decrease some of the discomfort with that. So all of them end in "ine," I always say diphenhydramine, so they end in "ine." So yeah, I'm gonna say "ine." Or Benadryl is the most well-known one. So I'll make you sleepy, but you will no longer be weepy. So the one thing to remember is that, not the one thing, but something to remember about diphenhydramine or Benadryl. is that it will make you drowsy. So some people just take this to help them sleep at night. So do not do things that are going to require your attention, and do not take this with things that are going to make you sleepy. So taking Benadryl and alcohol is a big no-no. It does have some anticholinergic effects, and we'll talk about anticholinergics when we talk about lower respiratory rate meds, but anticholinergics dry you out. And I don't know why I had to say that 6 times, but they dry you out. Hopefully I got it across, and I swear I don't have a stutter except for today. The lozenges can help for the dry mouth in order to help with some of those symptoms, because we want to take this med because it's going to be very helpful. But if their main complaint is, hey, I just feel really dry. And then also, I mean, with a lot of these patients, we're going to talk in respiratory in general, increasing your fluid intake is great. So you can also tell them to increase their fluid intake if that will help. They should report any palpitations, urinary retention, or any other serious anticholinergic effects. Some people can also have what's called a paradoxical reaction. This is a reaction where they are, Benadryl is supposed to make you sleepy, but some people, it just gets them on a high, like they've just done some cocaine or something, where they're restless, they're insomniac, they're like on 100, they're just like wired. And so just know that not everyone reacts the same way. So if they get that paradoxical reaction, they should not take this before bed. So that's Benadryl. And that's the first generation. So the first generation antihistamines, they have more of those sleepy side effects. So they came up with the second generation where they're like, hey, a lot of people don't want to take these because they can't take them during the day because they're getting too sleepy and they can't work. But here's the downside. Okay, well, these are going to not make you sleepy, but they're also going to cost $50 more than the first generation. They're super expensive unless you buy off brands, et cetera. But we're talking about the loratadine, fexofenadine, and the cetirizine. And just know in these, and like if you're a professional watching this, you can judge me all you want, but I can't pronounce stuff to save my life. That's why I call it Zyrtec. That's what the patient knows it as. But sadly, for nursing school exams, you guys do have to know all of the generic names. Second generation, less side effects, less of the anticholinergic stuff, so I don't have to worry about that. It doesn't make you as sleepy, but it is more expensive, so it is something to kind of keep in mind. Now let's talk about EpiPen. So we talked about for antihistamines, these can be used for prevention or for treatment of allergy issues. But then going on to EpiPen, this is when I'm having a full-on anaphylactic reaction. We haven't talked about anaphylaxis yet, but it's on the next slide, so don't worry. EpiPens are used for treatment. I don't preventatively, I don't say, oh, hey, I'm about to be exposed to something I get anaphylaxis for, I'm going to take my EpiPen. EpiPen is for treatment, not prevention. But I'm going to, so I can't prevent myself from going into anaphylaxis, but I can get emergency treatment through an EpiPen. So I'm going to carry my EpiPen around with me to prevent myself from dying of my anaphylaxis. That's the only prevention is carrying it around with you, but it's not going to be to prevent anaphylaxis. It's going to be to acutely treat it. So a patient always first needs to know, what does anaphylaxis, I can talk, look like? They need to know like kind of what their symptoms are or what to report, especially because a lot of people are young or kids and things like that can get this. So then whoever's around them, their teachers, their parents need to be educated on this. Like I said, always keep your EpiPen on you, monitor for expiration. They expire very easily. They usually last a few months, and sometimes people aren't going into anaphylaxis most of the time. So just like we'll talk about with insulin, that this can expire and then people will keep it forever and then it's not really working. You do not want an expired EpiPen. It will not save your life then. We inject it in the thigh, we cut them, and like I mentioned, the patient and family both will need education. You can teach kids how to give this, and they can learn how to do it very well. Something to tell patients is that they may need repeated doses. So they may take a dose and it's not like, oh, hey, now I'm good. Their airway can start to reclose, especially if they have a really serious, profound reaction. So they may need repeated doses. They may need multiple EpiPens, or like, it's not like, hey, I took my EpiPen, now I'm good. Like you still need to call and get help. So like after you do the injection, call and get help, but just know you might need more than one dose in order to get better. So I have a story, but I'm going to tell it a little bit. So what's the worst that could happen? So the worst that can happen with hypersensitivity is anaphylaxis. And what this is it's like, normally when you have a hypersensitivity reaction, it's local, like allergic rhinitis, it's, local up to my upper airway. With anaphylaxis or like hives, it's like local on my skin here. But anaphylaxis is a systemic reaction. And it's where, my really important organs like my heart and my lungs start to get affected. And pretty much what's happening is that with the, pretty much what happens is that because of histamine and how histamine works and stuff like that, all these inflammatory mediators are like widespread sent out that like the body's like, okay, be on alert. There's an allergen here. And so the body tries to help. And what it does is it constricts the airway, or you can have what's called bronchospasm, which is why they usually have this kind of, they can go unconscious because their airway literally closes off. They can get dyspneic, they can start wheezing. And then also they have a blood vessel issue where effectively what happens is because the body thinks it's in attack mode, it gets ready. It's like, hey, let's let down all of our barriers, all of our bridges. And what it does is it vasodilates. And what vasodilation does is it lets all your immune system get in and out of your blood vessels so much easier in order to, in order to effectively help to like get to where the problem is. Like pretty much think of when you're vasodilated, all the gates come down. So stuff can get in and out of your bloodstream a lot easier, which sounds great because it's great when you actually do have something you need to fight. But the problem is when you have vasodilation, your blood pressure drops like massively. And so like they have, so pretty much this patient, their airways closing, their blood pressure can drop profusely. They can die within, like minutes of this happening if it's not treated early. And so, like I say here, there's an airway problem. The airway becomes constricted and closes, so no oxygen can get in. And then they go into anaphylactic shock where the blood vessels dilate and they get low blood pressure. So this definitely can lead to a lot of very, very, very serious issues and death. So how are we going to treat it? So my first goal is to keep that airway patent. So a lot of people would say, well, don't you want to give oxygen? Well, you can't give oxygen if the airway's closed. So I have to open that airway first. So epinephrine, you have to do that first. If they don't have an open airway, there's no point. Epinephrine stimulates your fight or flight, opens your airway, constricts your blood vessels, and fix a lot of the issues that you're having. So then other things that I might do is give things like albuterol. That's going to help to open the airway and keep it open even more. And then we need to treat the problem. This is a hypersensitivity reaction. So I need to treat the problem, give diphenhydramine to decrease the allergy response. We usually give steroids to decrease the allergic response. And if there's swelling, especially in the airway, it'll help. Now steroids can be a little bit slower to come to the plate, but once you start giving them, they can be helpful. And then of course, and these are not in order, by the way. I'm not saying like you do albuterol, then you'd give diphenhydramine, then steroids. But the most important thing to remember is you do the epinephrine first. And then a lot of these, we're doing them all at the same time. And it's going to depend on the patient, what their needs are, what kind of reaction they're having. We usually do high flow O2. Again, airway must be open first. And then a lot of times this patient, not always, is going to need IV fluids. We're going to try to dilute some of those excess particles that they have that are causing that allergic response. And then we also want to help to because with the vasodilation, it's not that they actually lost fluid. It's just that like a lot of times the fluid slips out and like it goes into your cells versus being in the right place. But no matter what, their blood pressure is low. So we're usually trying to replace that fluid and then dilute those excess immune particles. So overall, what can we do to prevent complications for all hypersensitivity? Now, I'm not just talking about anaphylaxis, but all hypersensitivity. I always want to monitor their and assess their airway and breathing very closely. General teaching I might do is to avoid allergens. Again, keeping a diary, kind of figuring out what's bothering them, trying to stay away from it. I always joke about my friend that she does neurosurgical research. She loves it. Like it's always been her dream, but throughout college and everything, she has a horrible allergy, like really severe allergy, not anaphylactic severe, but really serious allergy to animal fur. But all of her research is on rats. And so she would always be all the time, she was chronically on so many meds. And every time we would go and hang out, my one friend had a dog and it was just always a mess for her. And so, we definitely want to try to avoid them. You can learn to live with them, but at the end of the day, it can be a hard life for those that want to be around something or they like a food that they know is going to make their airway close just a little bit. So yes. And so the other story I was going to tell before that I almost forgot with the anaphylaxis is I worked with a nurse when I was over at Baylor she had an allergy to nitrile gloves, which are what most of the gloves are in the hospital. So she had to bring her own gloves in. Perfect fix. Well, here's the thing is that one time she was in an emergent situation with the patient and someone reached over her and touched her with their nitrile glove on her hand or something very minor, and she went into full anaphylactic shock. They gave her epi and stuff like that, but she still progressed and she needed to be intubated. So just know like this stuff is really serious, and there's sometimes it's like, man, well, what if the job you want to do and the things you want to do require you to interact with your allergen? I mean, that's between you and something bigger than me, but it's just something to consider that that you might have to counsel a patient about the seriousness sometimes of this. And I'm not saying that that person needed to not be a nurse, but definitely there's sometimes only so many precautions you can take when it depends on how severe your reaction is too. Taking medications, preventative medications regularly is the best for optimal results and prior to exposure. We're going to talk about a lot of preventative medications when we talk about allergic rhinitis. We want them to know what to do when they have a reaction and what that reaction might look like, and then the emergency management, the signs and symptoms, and how to use that EpiPen if they do have that anaphylactic reaction. So let's talk about latex allergies, which is a little bit more specific. People with latex allergies can have a skin response or a respiratory reaction. And kind of a funny thing about latex is that there's a lot of foods that has been found that there's like proteins that are in some foods that are similar to those that are in the rubber of latex. And so commonly, if people are allergic to certain foods, we want to ask them about a latex allergy because there's like a cross sensitivity. So if people are allergic to banana, shellfish, avocado, kiwi, they usually are going to also be allergic to latex. And same with latex. If they have a latex allergy, we want to see how they've reacted to these foods or let them know, hey, you may have a reaction to these foods because they may not be aware. Maybe this is not stuff that they eat on a regular basis. So we always want to ask about a specific allergy to latex because some people don't consider it an allergy, even though it is. And so most hospitals and doctors' offices now use latex-free supplies, but some still use latex supplies. Look at all the things that can have latex in them. There's a lot of stuff. So you definitely want to be careful. There may be something as simple as a doorstop, like it's saying there, that you just wouldn't consider. So you want to teach about the related food allergies and what to avoid. Keep the work areas clean. If you do use latex, they should wear a medic alert bracelet so that people know they're allergic to latex, and they may need to carry an EpiPen with them, especially if they have a very serious reaction or sensitivity to that. So now let's talk about allergic rhinitis. So allergic rhinitis is a type of hypersensitivity disorder, and it's specific. It's more of a local problem. It's an upper respiratory. When we're talking about upper respiratory, we're talking about like stuff that's happening in the nose, mouth, throat, not going into the lungs, but just the upper airway. So this is allergic rhinitis is an over response to a stimuli that happens, and the symptoms are really going to be localized to the nose. It's not a life and death issue, but it can cause uncomfortable symptoms. And the patient's usually like, hey, they have itching in their eyes, they're sneezing a lot, they feel teary, they can't smell, and they can have clear, watery discharge. And that clear, watery discharge is important because as we're getting into other disorders and differentiating them, we want to differentiate the fact that this is clear. Whereas when we're talking about infection issues like that, we're getting into more purulent or yellow. Rhinitis is a clear, watery drainage. So how can I make it better? Well, my goals here is, of course, to decrease the inflammation that's going on, encouraging patient to avoid their triggers like we do for all hypersensitivity. But then there's a variety of meds, and we're going to go into them one by one. But a key here when you're studying these upper respiratory meds is looking at, are they going to help prevent an attack, or are they going to help to treat? And as you can see here, the only one that's actually going to help treat is antihistamines. All the other ones are going to be used, including antihistamines, are going to be used to prevent attacks. So you can see a lot of allergic rhinitis treatment is going to be centered around preventing these problems. So let's talk about nasal corticosteroids. When I say nasal, I mean that I'm doing a nasal spray. So the most common one is the Flonase, and this is a steroid. And a good way to remember all steroids, this happens if they're IV or otherwise inhaled. They all in their own and ide, and I always remember own and ide help inflammation hide. And I'll have that on another slide, I believe. But own and ide help inflammation hide, if that helps you to remember that these are steroids. Since it's local, there's minimal systemic absorption, so I'm not as worried about like the depressed immune system or like whole body immune system being depressed or the increased blood glucose, but it's possible it could happen. Mainly what people complain about is nasal irritation, like it can just kind of cause like a burning or discomfort. We want to teach these patients to use their nasal spray on a regular basis. It can take several days to weeks before it's actually going to start working. So don't like use it a day and be like, it's not working, my allergies aren't getting better. And then tell them to blow their nose before. We don't want, like if they have a bunch of mucus in their nose, that medication is not going to be able to get right to those tissues the way that we want it to. There's also what are known as mast cell stabilizers. This would be like cromolyn nasal spray. Again, we're going topically right to the source. And when I say cancels the reaction of mold, that's just in mnemonic. I don't necessarily mean that it's only used for mold, but it's just one way to remember it. And it's used for, again, for prevention, not treatment. A lot of people will use it about a few weeks before allergy season starts, or you can use it before being exposed to an allergen if you have an isolated allergy versus just seasonal allergies as well. But all of these, like steroids, decrease inflammation or decrease your immune response, because remember, this is an over-response, overreaction of the body. Mast cell stabilizers, mast cells are another key player in that over-response that the immune system is having. And so mast cell stabilizers help to stabilize the mast cells so that they are not overreacting, releasing all of those particles that are causing that overreaction. There's also an oral medication known as Singulair, also known as a leukotriene receptor antagonist, or LTRAs. And I remember this one because they all end in cast, K-A-S-T, and so they cast away allergy symptoms. For these, some things that you'll want to know is you want to monitor liver function for these patients. You always want to take them on an empty stomach for best absorption, things like that, and never stop taking them suddenly. And kind of a funny side story about this, you know, my husband's been on just about every allergy med and tried everything with all the allergy issues he still has to this day. And so when he went on this one, there's a newer reaction that some people are having to this, where they're actually having like suicidal ideation. Like he's the happiest go lucky guy you could meet. And I remember after he started taking this, he like texted me after like, you know, like in the middle of his workday, and he's like, I just feel like there's no hope in the world. He started having like these senses of doom. He was like, what's the point of living? And he started getting very suicidal, and he had to talk to his doctor because you're not supposed to stop it suddenly. But for him, he did have to stop it suddenly because it was causing him to have like suicidal thoughts and feel very depressed and very down. So just know that there is like, it's a very rare thing. It's not a lot of people are having it, but it is something new that's coming up with this Montelukast and our Singulair. And so definitely something to kind of ask about. Don't forget to do a mood assessment on your patient. So other treatments and things that we can do for allergic rhinitis, we can do things like those allergy shots like we brought up before, if it's an isolated allergy, keeping the symptoms diary and avoiding triggers, and then doing things to generally keep my house clean, things like removing carpeting, because carpet can hold on to more particles and things more than other things can, so we definitely want to keep an eye on that. Using an air filter to help clean out particles that might be in the air that could be irritating, that your body's overreacting to. Keeping a cool and dry temperature, moisture definitely leads to things growing that can be irritating. Keep things clean, and having good ventilation is key. And there's some other, there's some other things here, like keeping your pets out of the bedroom, avoiding smoke particles, taking off your shoes, that kind of stuff too can help. So now let's talk about sinusitis. And there's acute and chronic sinusitis. Effectively, this is kind of like taking a step up from rhinitis, because a lot of times rhinitis can lead to sinusitis. Usually most of the time what's going on here is that there is an infection or some, there's either an obstruction because you have so much mucus, maybe from, having allergic rhinitis or something, or you get an infection, which then leads to this inflammation, irritation. There's an inflammation, just like there is in rhinitis, and swelling of the nasal passages, just like in rhinitis, but it gets to the point where the nose actually gets blocked, like the sinuses get blocked. And this is not a good thing because, like you can see here, like mucus builds up and then mucus is just sitting there, which leads, like if there wasn't an infection, then it can lead to an infection. We're going to talk about it later in the semester, but it's kind of like with urinary retention. If I have urine just sitting in my bladder, there's a high chance that infection is just going to chill out and come on in and start cause an infection. Like anytime there's stuff just sitting around, like if you have blood just sitting around in your blood vessels, like pooling, like in vasodilation, that's going to be a higher risk for clots. Anytime there's something just sitting, just kind of, I'm trying to think of a word, but I can't come of the word. Like I was going to say, just, I don't want to say melting, that sounds disgusting, but just chilling. I guess that's the most professional word that this professor can come up with. There's just some stuff just chilling out together. There's a high risk for either infection, something coming in. So in this case, what I'm worried about, maybe stewing would be a better word. It's probably a little bit more professional than chilling. But stewing, if mucus is just stewing here in the sinus passages, then I'm going to be worried about infection. This patient's going to be a little different, versus the allergic rhinitis patient that had mostly kind of itchy, watery symptoms. This person's going to have pain. They're going to have pain on their sinuses, like here around their nose. They can kind of have it here across their forehead too. Sinus pain, the main symptom they usually complain of is feeling congested, like just feeling like they're full of junk in their sinuses. They can be weak. They can possibly have a fever. And if there is an infection, they more often are going to have that yellow or green purulent drainage from their nose compared to that clear drainage you get with allergic rhinitis. So how can we make it better with medications? So there's a variety of medications. First and foremost, we're going to try to treat some of those symptoms that are really uncomfortable, and that's going to be like decreasing congestion, decongestants, which we'll talk about. We also want medications that are going to thin secretions and get stuff up, like expectorants, and we'll also do other interventions to help thin secretions. We'll talk about that. If they have pain and fever, we may do stuff like acetaminophen or Tylenol, and then depending on what other symptoms they may have, we may use like antihistamines to help to decrease some of those. So let's add in some more medications because I know you guys love them. So other medications, there's what are called decongestants, and just like the name suggests, they are going to deconstruct your congestion or decongest you. What they do, because if you I didn't talk about this, but what's actually happening with that swelling in your nasal passages is there's a vasodilation in those blood vessels. And so what decongestants do is they constrict those blood vessels. Like pretty much because the blood vessels are swollen and dilated, there's less space in your sinus passages. But what this does is causes constriction, which helps to open up and lead to a better ability to breathe. So most people know decongestions like pseudoephedrine or Sudafed. There's also more, there's nasal ones like Afrin nasal spray and stuff like that, that can be used as well. But something to keep in mind, if this is something that constricts my blood vessels, it's not going to be safe for those that have heart disease, hypertension, some diabetes, blood vessel issues, flow issues. So it can increase your blood pressure, increase your heart rate. It can cause insomnia, eye pressure, excitability, a lot of side effects. So that's why, most of the time, like Sudafed used to be like very, safe and effective and stuff like that. But now a lot of people are abusing it and using it for crazy things. So yeah, you always got to be careful. But that's why a lot of times with some of these meds, you have to like give your ID, like you're signing away your life when you're really just congested. So but needless to say, you want to be careful and look at your patient's history, and the doctor will decide if it's safe for that patient. For the nasal sprays, the nasal decongestants, we should not use them for more than 3 days or more than 3 or 4 times a day. And we're going to watch out for what's called rebound nasal congestion, which I'm going to talk about. Students always find this confusing. So what is rebound congestion? It's not well understood, but what's thought is that the constriction of the blood vessels from the medication leads to an inadequate blood supply, which then leads to further swelling in the nasal passages. So that swelling comes back, even though the medicine's supposed to be helping, it actually leads to more swelling as a result of the vasoconstriction. But there's also, it's believed that you can build up a tolerance to this medication and it stops working because people overuse it. They're like, I'm so congested, and they'll use it like 7-8 times a day. So it's definitely important, like I brought up here, no longer than more than 3 days or no more than 3 or 4 times per day. Otherwise, they're going to be higher chance for building it up. So whereas with steroids, we can use them long term and decrease swelling. For these decongestants, we can only use them for a few days. So it's very important to note that because a lot of people mix up these and nasal steroids. So there's also what are called expectorants, and expectorants help to get secretions up and out. So this is going to be stuff like guaiacin, which is Mucinex. It helps to thin mucus to make it easier to get it out. So you should expect to be coughing stuff up, or guaiacin will make it thin. It's another way. And like I was saying, the other thing that you really want to do with this, in order to make guaiacin more effective, we're going to want to increase our fluid intake as well, because that's going to help thin secretions even more. Like as a whole, I brought up before that increased fluid intake is super helpful for any patient, or I want to say most patients with respiratory problems. We want them to increase their fluid intake. Because it helps to kind of thin stuff out. So it's a lot easier to cough up thin secretions than it is those thick ones. But yeah, that's another medication that can be used. And then, like I mentioned, there's acetaminophen. It's a mild pain reliever. It helps to relieve pain and fever. So if there is an infection, and a lot of times when it's sinusitis, 9 times out of 10 it's a virus, and so there's not like I can give antibiotics and stuff like that, and antibiotics are usually the last ditch effort, which I think I'm going to talk about on the next slide, I believe. But just in case I did forget to mention that, like we only do antibiotics if things aren't better after like a week or so, but most of the time it's viral, so they're not going to be very helpful. But if it persists, or sometimes it starts as a virus, then turns into a bacteria, because remember, all that stuff stewing, together can lead to infection. Keep in mind with acetaminophen, it's hard on the liver. It's contraindicated in those that are alcoholics, or should say those with severe liver disease, and they may need to monitor their liver function testing regularly while they're if they regularly need to take this. So how else can we increase comfort? So a lot of it's going to be about heat, rest, and fluids. So, rest is going to help to prevent infection, decrease stress, etc. Increasing your fluids will loosen those secretions. A lot of people will do like hot showers or steam inhalers that helps promote drainage. Damp and warm towels on the sinuses, like actually literally on the sinuses around here and on the forehead, can help with pain relief. Sleeping with the head of bed elevated help. You have to think about drainage. You have to think about your sinuses and the way they drain. If I'm laying flat, like all my mucus is going to go back instead of coming out. And so it's kind of like, if you were going at like, of course, there might be people of very different ages watching this video, but I'm going to assume you're all 21 and legally drinking in the United States, or wherever country you're at, if it's legal. But let's say you went out for a hard night, you drank too much, you're worried about throwing up. Usually you want to sleep on your side or near a trash can, etc., to get stuff out. So it's kind of the same thing, except you want to sleep with your head of bed elevated, because it's going to allow for drainage of the sinuses, allow stuff to come out naturally. Saline washes, so rinsing the neti pot and stuff like that 1 to 2 times a day. Avoiding things that are irritating, like smoking cigarette smoke. And then, like I said, if symptoms persist, it may need antibiotics, but we always do least invasive first, because most of this, like allergic rhinitis and acute sinusitis, even if it turns into chronic, like most of the stuff, like we're trying to manage the symptoms. It's not usually a life or death thing, or like there's like a serious, like as the nurse, like a lot of the disease process we're going to talk about in respiratory, I'm going to tell you, oh, hey, here's a warning sign that things are getting worse. But this isn't one of those. There's not like, it's uncomfortable symptoms. Definitely want to manage them. Definitely don't want them getting infections and stuff like that. But most of it's just symptom management and then secretion management. But if it does not get better, usually if symptoms persist, we will do antibiotics. So last but not least, let's talk about influenza. So what's the big deal here? with influenza? Well, first and foremost, a lot of people get this confused. I think the flu is a lung problem, and the flu is actually an upper respiratory disorder. Flu is upper respiratory because even though it seems like, hey, that like everyone, like they're coughing and people think, hey, I'm coughing, it must be a lung problem. It's actually like a throat upper airway problem. It's a virus. And real quick before I go on, the reason I want to bring up that it's an upper respiratory versus a lower respiratory, the important for you to know that is because this is an upper respiratory problem. So if they start having lower respiratory or lung symptoms, that's usually my cue that something is going on that's new or bad. We'll talk about that. But anyway, so it's a very highly contagious virus, and there's a flu season. It's around like what, October to June or October to May or something like that. Might even be before then. I am not an epidemiologist, and I'm fine with admitting that. It's around that time though. Usually you have to get vaccinated around by, as a healthcare worker, around October. And I want to say that it lasts till like May or June. So yes, it's always lasts longer than what I think it should, because I was like, is flu season still going on? But it is. Every flu season is different. In other words, every year the flu virus gets together with all of its buddies and says, hey, who should we be this year? Which costume should we put on? And they come up with some crazy new virus, they mutate, etc., swap some genetics. And so every year there's a different flu vaccine. We'll talk about the vaccine here in a second. So transmission is through droplet precautions. Effectively, what that means is that when I cough, like in the stuff that's coming out of my mouth is what's coming. It's not airborne, but it's droplet that if I cough, it's going, my drops of my sputum and spit can transmit that to you. So usually this is where we'll wear a mask, or have the patient wear a mask, I should say, more than anything. We're going to wear a mask going in, but they're going to wear a mask as well. Which is not a problem at all right now, since we're all wearing masks anyway, right? The patient is going to complain about having, they're not going to say, oh, I have a high fever, but they might, but they're going to have a fever. They're going to feel hot, sweaty. They're going to be weak and achy, and have a sore throat often. So I think it's helpful. And again, this is not my picture. It's the beautifully done by the Nursing Education Consultants Incorporated. Thank you so much, guys. You are wonderful. This picture is depicting the difference between a cold and the flu, because a lot of people mix these up, because a lot of people are like, well, is it a cold or is it the flu? And how do I know? The big difference is in severity. So you can see here with a cold that they have like much more mild symptoms, like they might have a headache, their temp can be normal, slight aches and pains, slightly mild or moderate cough. Whereas with the flu, it's more severe. They have a headache, high temp, severe aches and pains, extreme fatigue and weakness, can last weeks, severe cough, chest discomfort, etc. So you can see it's really in the severity. So like I said, well, we always want to be watching out for those lung symptoms, because if they're having lung symptoms, it's usually a sign that something's progressing or getting worse. And so the worst thing that can happen is getting from influenza is going to be pneumonia and respiratory failure. And I'm not saying like that's the only thing that can happen, but I'm saying like that's some of the scariest, or I should say more common, and stuff I need to be watching out for as the nurse. So I need to be listening to their lung sounds. A patient with influenza should have clear lung sounds because it's not in their lungs, it's an upper respiratory thing. If their lung sounds are wet or coarse, then I'm going to be concerned that they are getting like a secondary infection or a secondary pneumonia from their influenza. If they're complaining of difficulty breathing, because this is not a problem in the alveoli, which is where your oxygen goes in and out. If I'm starting to have problems with oxygenation, there's something going on in my lungs, not in my upper respiratory. A new fever, maybe they were getting better and now suddenly they're getting worse. Worsening of any of their symptoms. Purulent sputum, because again, this is an upper airway thing, not a lower airway thing. So if I'm starting to cough up sputum that's very, what we call it, yellow, green, thick stuff, I'm going to be worried that they're starting to have a lower respiratory problem going on. So how can we prevent the flu? Hygiene is key to prevent the flu. So making sure that, especially during flu season, hand washing, getting immunized and stuff like that is key, especially for the high-risk groups. So I'm going to talk a little bit about vaccination here, and I'm not talking about this from a personal opinion perspective. I'm talking about it from a nurse-centered and textbook perspective. So if you're on here just watching this for fun, which I don't know why anyone would watch this lecture for fun, but no judgment if you just really find this fun or interesting. But I'm not here to get controversial. I'm here just to teach nursing students what they need to know in order to do well on their exams and to move forward and become a safe and competent nurse. So the flu vaccine is given every year, and it's usually mandated for healthcare workers. And we want to think about who's going to be highest risk for getting it. So the people that are highest risk for getting it, of course, healthcare workers. Most people would probably think people that are like diabetic and stuff like that. And yes, though they're going to be more at risk, but people that are around sick people are going to be first and foremost, like so paramedics, healthcare workers, also people that live or work in long-term facilities like LTACs are going to be super at risk because they're around so many patients, and especially a lot of their patients are older. We can start getting the vaccine as early as 6 months. So, babies younger than that cannot get the flu vaccine, but they can start getting it at age 6 months. And most people get it every year. The teaching we want to give around this is the vaccine's not just for you. So I know that, a lot of people, there's some conceptions that if you get a vaccine, it's supposed to help to prevent you from getting this. And the point of a vaccine is not to stop you from getting the flu, it's to stop you from dying from it. So it's just really important to note that a lot of times there is some miseducation when it comes to that, like I know I have some family members like, hey, I'm not even going to get the vaccine because I get the flu every year anyway, but they never ended up in the hospital. They had a very mild flu, etc. It's no fun. I mean, it would be great if we had a shot that just like saved us. We did not get this at all. But what vaccines really do is stop us from ending up in the ICU or dying from this. And there's been years we've had some really young, really sick people in our ICUs that were unvaccinated from the flu. And it's just hard to see for sure. So it takes 2 weeks to get full protection. So sadly, for some people, they get their vaccination and then within that 2-week period, they end up getting the flu in that 2-week period. And then they're like, it doesn't work. And so it's hard stuff. So sometimes it's just about making sure that you're educating patients and letting them know about what to expect from this and when this is going to work for them. And when I say work, again, I mean prevent them from dying from this. So the influenza vaccine can be inactivated, so it can be given via injection. That's how most people receive it. Or it can be attenuated or a live vaccine, which means it's the live virus, nasal spray. So the difference here is that when you're giving the inactivated or injectable injection, this is just giving, helping you, your body's going to take in that vaccine and it's going to form an immune response to whatever's in that vaccine. And since it's a dead virus, it's not going to need as much of an immune response because it's like, oh, hey, there's this virus here. I'm going to form a response, but it doesn't have to kill itself to build up a response. With an attenuated, there's a live virus. So think of it like I have to be on attack right now. My immune system needs to come right now and fight this. So the thing I'm really trying to say here is that the inactivated, which most people get, this is going to be great for people that don't have a good immune system. If I don't have a good immune system, I don't want to put a live virus inside myself and say, here you go, good luck, sucker. That's just not good. I'm sorry, I shouldn't have said sucker, that was rude. But sometimes it just comes out. But you know what I'm trying to say is that as a whole, what I'm saying is that we don't want to give a live vaccine or an attenuated vaccine to someone who is can't fight it, doesn't have the immune system that can really fight off that infection. So that's why most people that are like diabetic, COPD, or have chronic medical conditions are going to get the inactivated vaccine, the injection. That's what most people get anyway. But people that are young, healthy, don't have a lot of other medical conditions, they can get the nasal spray and they can be okay with that because they have the immune system to support them to build this up. But definitely, so as healthcare workers, we are required to get this, or you can get a waiver, et cetera, if you have religious or other reasons, et cetera. But it's usually required for most hospitals to get this every year. And then when patients are in the hospital, we also regularly immunize them. And so as a nurse, you may come into touch with this, either screening your patients for the vaccine or making sure that you take care of it for your own compliance as well. So how can we treat influenza or make it better? So medications such as acetaminophen that helps to treat aches and fever, like we talked about before. We can give antitussives, which I'm going to talk about on the next slide, which help to decrease cough. We can give that guaiacin or expectorants to help thin mucus and get the secretions up. And then one that's specific to influenza is what's called seltamivir or Tamiflu. I always remember Tammy will make you feel less clammy. This is an antiviral, and so it's not given to everyone who has the flu. We had one flu season that was really bad. We were just giving it to everyone because it was like just a shot in the dark, because like there were so many people who were so sick and dying from it. But most of the time we're only really given if it's the first few days of symptoms, because it doesn't stop you from having the flu, but it stops viral replication, which can decrease some of your symptoms and decrease how long you're experiencing the flu. But it's only really helpful if you take it those first few days, because otherwise that viral replication has already happened and you're just living in that flu. Rest and hydration is key for these patients. And a lot of the other stuff we kind of talked about with the upper respiratory stuff, like to help with some of the uncomfortable symptoms. So last but not least, let's talk about antitussives. These are anti-cough medicines. Anti-cough medicines, they're anti-cough medicines that help you to not cough as much. And so they decrease your cough or your cough reflex. Keep in mind, pretty much all of these can lead to drowsiness and dizziness, or the 2 Ds. So you definitely want to alert the patient to that, change position slowly, and not be doing things that maybe require extra alertness. There's Tessalon pearls, which you'll see often prescribed in the hospital, and there's some mnemonics there for you, or dextromethorphan. I'm going to say that probably very badly. And so both of these can be used. They are non-opioids, but a lot of times people are taking a lot of these cough suppressants and turning them into drugs and other things. So that's the other not fun part of nursing, is finding out all the medications we like to use for patients are sadly now being used for other things as well. But that's a whole bigger problem than what we can talk about on this PowerPoint slide today. So codeine is an opioid that can be used. Too much codeine can leave you coding. So always keep that in mind, is that it's a very, it's an opioid. So there is a concern for addiction, and it can cause respiratory depression. So you have to, that's why you need to watch out for them coding. You definitely don't want to take too much. A lot of times people come in overdosing on codeine. So you definitely have to be careful with that. So something to note about antitussives or decreasing the cough is generally, most of the time, especially when it comes to infection, I don't want to decrease the cough. If I decrease their cough, then they're not going to be coughing up all that yucky sputum that has infection and stuff in it. So generally I use these only if it's very severe, like they're just so uncomfortable, or they're having a cough like we're going to talk about with acute bronchitis. They can be coughing for months, like severe coughing, and it's just hacking cough, and they can't sleep. That's when these really come in handy. But usually these are more of a not a last-ditch effort. It's not that we never give them, but we don't necessarily encourage a patient not to cough. In most respiratory things, we want coughing and deep breathing, because that's going to help to get stuff up, to keep our respiratory passages clear and keep everything open. But that's my little spiel on antitussives. So that is all I've got for upper respiratory. There will be a separate presentation on lower respiratory if you can still stand me and my jokes. Anyway, hope this helped. See you in the next one.